Welcome back, everyone. It's so great to see the room so full and so quiet after so soon after the break. I am really excited. I was just told this is the trifecta of STD Talks. So I am really excited to introduce Natalie Neu, who's a professor of pediatrics at Columbia University, who's going to give us a talk that is essentially all STIs that aren't syphilis. So a lot to cover, real focus on the guidelines and what's new and what you all make sure you all are aware of. So welcome.
Thank you, everyone, for coming back after your break. And thank you to the organizers for inviting me, and especially my friend John Nelson. Today, we're going to talk about STIs. And I have to say, it's not going to be really anything new, probably. But I really want you to come away from this thinking about how you can talk with your patients about STIs, how you can teach others about STIs, and how to effectively test and treat for STIs in our population that we're working with. So I do work on some DSMBs, as listed here. So today, we're going to list some of the common STIs. There are many, and especially those that impact HIV-infected populations. We're going to describe appropriate screening tests and also some recommendations that are really population-based. And this has been a new focus for the 2021 guidelines. We're also going to discuss briefly some appropriate treatments for STIs. So we have our first question here, and my questions are more of like what you probably get in kindergarten, like we want you to say, get the right answer. So when should I screen for STIs in my patient population? Twice a year when doing T cells and viral loads, only screen MSM or pregnant women, screen at least annually, but as often as every 3 months, no need to screen, test for symptoms. And personally, I always fail trick questions, so I don't want you to fail this. I think we're good. Perfect. So I can just leave, right? No. Anyway, we're gonna talk a little bit and go over some principles that most of you know. Hopefully I'll give you some information that'll be helpful when you're teaching residents or students in your clinic. So as you know, epidemiology is really critical to understanding STIs. This data is from 2022, and as mentioned previously, the 2023 data just got released last week, but it's pretty much the same. There are over 1.6 million cases of chlamydia, and that number really hasn't changed, maybe a 1% change in that. Gonorrhea cases are in 22 were close to 650,000 annually, and that actually has decreased by about 7% in 2023, which may be related to screening, maybe not. The data is still out. We've already heard about syphilis and congenital syphilis, and what remains a concern to everyone is that STIs are very prevalent amongst specific populations, and these are the populations that we're working with. So young adults, 15 to 24, gay and bisexual men, pregnant women, which is really, really important that we include them in our evaluations and talk about sex, and also racial and ethnic minorities. That has not changed. So what's key to our understanding of STI information and how we can improve or know more about our data is through surveillance. And the key to that is testing. So the 2021 guidelines really focused on testing, understanding testing for key populations. And so we're going to talk about that a little bit more specifically. And we know screening is important, right? Because STIs oftentimes, up to 70% of patients are asymptomatic. So the only way we're going to know that they're there is by screening. And in fact, I spent my break actually telling somebody they need to get treated for gonorrhea, who said, I have nothing, and somebody else who has herpes, who had a little lesion. So I think that they're out there, and we've got to make sure that we're testing, especially those who are asymptomatic. I want to use a case just as an example to sort of jump into about testing populations. So Jessie's a 17-year-old cisgender female, perennially infected with HIV, has 2 male partners in the past 6 months, 1 female, practices oral, vaginal, and anal intercourse, and uses condoms, but occasionally, and definitely never uses them for oral sex. That's pretty much a no-brainer. Has had chlamydia in the past. Her partner recently says they've had chlamydia and has no intention of getting pregnant. So with this, this case presentation, I want you to sort of, in addition to understanding the history of the patient, gives you an algorithm of how to talk to your patients, right? And this is also available on the CDC website. You want to know about partners, practices, prevention, previous STIs, and pregnancy. So there's a reason why I'm giving you these 5 Ps. So what's new about testing for women? So really, it's about expanding our testing. So part of this is, again, taking your sexual history. You've already done that. You do the 5 Ps. It's also about shared decision making. So why was there a change in the guidelines to expand to extragenital testing to women? And the reason for this was that many papers and studies that were done recently, and one very large review paper that looked at 33 studies of women showing that sexually transmitted infections occur at sites where maybe people are not identifying that they're having sex. So for example, rectal gonorrhea was identified in up to 35% of women in these studies, and rectal chlamydia was also identified, but up to 77%. So had you not tested extragenitally and you only did urine in those patient population, you would have missed almost half or 3/4 of the cases of an STI. And we know that if we were just to test at those 3 sites, we could significantly impact transmission of STIs. And we also know that also impacts the transmission of HIV. So this is the reason why the emphasis on extragenital testing and including women in that testing paradigm. Testing for transgender and gender diverse populations also, the emphasis and the discussion is around testing at the, based on anatomy. So transgender men with a cervix need to be tested at that site. Transgender men with a neophallus without vaginectomy need to have a vaginal swab. So just think about what is the anatomy that is there and test at those sites. We've talked about, in general, testing annually, and multi-site testing, but you can test as often as somebody actually needs to get tested, as long as it's can be paid for by insurance. So that's something you have to look at, and we need to advocate for. Women, we already mentioned, multi-site testing is really preferred. So why, again, let's dig a little bit deeper. Why this emphasis on extragenital testing? Well, some of it, the data is based on studies, and this is a study that was done, I think, in 2019, or the health department, where they looked at close to 10,000 clinical encounters. And they found that if they hadn't done extragenital testing, they would have missed diagnoses. And we know that gonorrhea in the pharynx is different than gonorrhea in the urinary tract. This figure here shows, I'm just going to walk you through it for a second, why we would emphasize extragenital testing. So on the top part of the figure, you see the pharyngeal location. On the bottom part of these 2 figures is the rectal. The grayed out bars are if you have both extragenital and urinary tract testing, and the black bar is if you did extragenital alone. So you can see here that if you did not do extragenital testing, you would miss all those black bars. So MSM, of course, that sticks out to us, right? For gonorrhea, or for chlamydia of the rectum. But look at the black bars for women. So those are the ones that are highlighted here. Those are misdiagnoses if you did not test extragenitally. And thus, we have data to support testing at extragenital sites. What do we know about correctional facility and testing? So right now, the emphasis is on testing, opt-out testing for folks who have been in or just immediately released from correctional facilities. So why is this screening emphasized? And for certain populations, there's certain age limits. So, you know, women less than 35, men less than 30, for example. Also an emphasis on syphilis screening, which you've already heard about, and HIV testing and PrEP. So if you see the figure on the right-hand side, the emphasis was on doing opt-out testing, because if we did opt-out testing, they identified in this study that the prevalence of STIs, especially for chlamydia, was 10%, versus if they did opt-in testing, it was only close to 6%. Now, the same was not true in terms of the prevalence data for gonorrhea, and that might be because more of the cases of gonorrhea present with symptoms, and so they would have been excluded from the study. The other thing that's really important that I don't have a slide on here is that many of these folks who tested for STIs had a viral load above 200. So having active HIV, uncontrolled HIV, and having an STI, we know, is associated with an increased risk of transmission of HIV. And so it's really, really important that we test folks, and we also give appropriate treatment in these settings also, because it impacts the transmission of HIV. So this summary table is provided for you to sort of think about who do we recommend screening for and how often. So men who have sex with men test at each site of exposure, but even we know that some folks really don't want to reveal their site of exposure, and sometimes that data is missed. So testing at 3 sites, even if not identified by the patient, is very, very important. And even as soon as every 3 months could also be supported. Folks on PrEP, people with HIV, and especially pregnant women, it's very important to test, and I think our last speaker also identified testing pregnant women is very, very important, especially in the 3rd trimester. So let's talk a little bit about discharge diseases. So we're going to look at another case. Jack is a 25-year-old. He walks into clinic. He has 6 male partners in the past 2 months. He meets his partners on apps. He has 1 regular female partner, practices oral, vaginal, and anal intercourse, sometimes uses condoms, has had chlamydia in the past, and doesn't want to have children. Again, the 5 Ps. If you just have that in your mind, this is how I'm going to ask the questions, this is how I know what I'm supposed to do for this person, that is going to be really helpful in terms of your time management and your patients, because I know we all have a lot of patients to see. So MSM, we just discussed the standard testing is this is what we offer in our clinic when folks come in. 3-site testing is incredibly important. Self-testing really is something that we've moved directly towards. I know it will then lead to less examination of the genital tract, but you can still examine the genital tract in patients. It just has to be in a shared discussion with them. Self-testing can be done. And we know in many, many studies that self-testing actually is as good as provider-collected testing. You do have to have or perform a validation study. You should talk to your lab about whether this is possible in your setting. But patients often will do this, even if they say, no, I'm not having anal sex, but sure, okay, give me the test and I'll do it myself. So I think that really increases your testing and is super, super important. So just to follow up on Jack, when you talk to him, he does describe that he has discharge. The discharge identifies, you actually have a microscope. I don't know who has a microscope anymore, but he does have gram-negative intracellular diplococci, and you diagnose him with gonorrhea. So what would you treat him with? You're going to give him azithromycin, 2 grams, ceftriaxone, 500, levo, 500, ceftriaxone plus doxy. Remember, I'm not trying to trick you. All right, we're close to 200, so let's see what you guys say. Awesome. So people want to give him ceftriaxone. fabulous, and at 500 milligrams. I do agree that you don't totally know if he doesn't have chlamydia, and oftentimes, as we've discussed, many STIs run together, so you would not be wrong if you also gave him doxy. And even if your test came back later negative, you could call him and say, okay, go ahead and stop the doxycycline. So that answer is not wrong. So the guidelines do talk about treatment for gonorrhea and uncomplicated PID, proctitis, and epididymitis using 500 milligrams of ceftriaxone, but is weight-based dosing. So folks who are above 150 kilos, and unfortunately in the US, as we have heard from our speakers yesterday, we do have a problem with folks who are having more weight. So you do have to increase the dose up to 1 gram for those who are above 150 kilos. If you have not excluded chlamydia, you can also treat for chlamydia, as we discussed. We're no longer recommending dual therapy, and we'll talk a little bit more about why that is at this point, but that was a significant change to the guidelines. Alternatives, if ceftriaxone is not available, there is a single oral alternative, cefixime. Remember, this is a higher dose. This is also sometimes difficult to get, I think, for people. It's really hard to get from the pharmacy. Sometimes you have to prescribe cefixime as treatment for otitis media or for UTI, and that way you can get the 800 milligram dose unless you have it readily available in your clinic. There are other injectables that you can give, so gentamicin, if you can get it into your clinic and have that as a mainstay, but many clinics definitely don't have this available, and that should be given with 2 grams of azithromycin. I want you to remember, though, there really is not a reliable alternative for pharyngeal gonorrhea than ceftriaxone. So this is really, when you have somebody with pharyngeal gonorrhea, this is a very difficult it is difficult to treat. But if you have somebody, for example, I had a patient who, HIV-infected patient, bone marrow transplant, had DRESS, so a drug reaction with eosinophilia and systemic symptoms to cefepime. I couldn't give him ceftriaxone. I was discussing with my PharmD, what do I do? And so, I was wringing my hands. We did give him azithromycin, 2 grams, and called him back, quickly to get a test for reinfection. So I think you have to make way for all these situations. You have to weigh the risk-benefit and deciding what you're going to do with that therapy, but close follow-up is absolutely important. So why were these changes made? So we've talked about, and the speaker before, you'd see all these ID people were all about stewardship. So a lot of it is about antimicrobial stewardship. We know that from all the studies that have been happening that there is a rise in resistant gonorrhea, and the minimum inhibitory concentrations for killing this organism have gone up over time. We also know that with our use of antibiotics, with being able to go to the local bodega and pick up some azithromycin, and also prescribers, if you have a cold, giving azithromycin willy-nilly, we've seen a huge amount of increased resistance, especially to some of these commonly used antimicrobials. It impacts not just our STIs in terms of resistance, but our microbiome, in addition, is being impacted by resistance. And then also we know that, that there's problems with the pharmacokinetics and pharmacodynamics. So what do we know about this, and why is this so important with the change in the dose? So we know that for ceftriaxone, I described that we're seeing increased minimum inhibitory concentration. So we know that. What does that mean? We need to get the drug in the body at a level above the minimum amount to kill it for a period of time. So in some modeling studies, this was found to be 500 milligrams. In other countries, so in the UK, in Australia, they're already up to 1 gram for their organisms. So I wouldn't be surprised seeing this also in the future come to the US, but right now 500 milligrams is the standard dose. We do know also that for pharyngeal infections, that's sort of like a hidden site for infection. If people are not doing 3-site testing and you don't know that they have pharyngeal gonorrhea, then if you don't use the appropriate therapy with the appropriate dose, you're not going to kill the organism. So it's really, really important that we do the 3-site testing and we use this higher dose. Finally, I want to just emphasize to you all, the only test of cure that's now recommended in the guidelines is really for pharyngeal gonorrhea, and this is because it is such a difficult location to treat gonorrhea, and so we do like to retest 7 to 14 days. Personally, I go on the more of the 14-day time frame because we know that if you test at 7 days, you have a risk for having a false positive NAT test because the test is very, very sensitive. So up to maybe about 5% of cases will still be sort of detecting dead organisms by a week. It goes down to around 1 to 2% by 14 days. So having that time frame for coming in and retesting is critical. For other infections, it's test for reinfection is what's emphasized because we know everyone loves sex, right? Everyone loves sex. So they might get reinfected. So we need to have them come in, stay in our clinical practice, and test them for possible reinfection. So overall, I don't want to scare everybody, but this is kind of where we're going in the U.S. So overall, reduced susceptibility to antimicrobial therapy over this timeline from the late 80s to 2019, the antibiotic susceptibility has gone down from 76% to 45% overall. You see from this figure, the blue line represents ciprofloxacin, fluoroquinolone, very similar to levofloxacin, where the rates of resistant organisms are up to 30%, especially in the MSM population. Likewise, you can see that trajectory of the azithromycin, the green line, just shooting up, and this could have been impacted by the recommendation for dual therapy. And so, as we mentioned before, dual therapy has been removed from the guidelines. So what's new with GC? Besides being afraid that we won't be able to treat it, it's really understanding mechanisms of resistance. So this table on the left looks at mechanisms of resistance. We know that for ciprofloxacin, the gyrase gene is one that has been identified as being significant for ciprofloxacin resistance. PEN-A, the PEN-A gene and the genes for azithromycin have also been identified. So understanding these mechanisms of resistance, creating products and tools for identifying this resistance either in our laboratories or point of care testing may be the way that we're going to go in the future so that we can preserve or reuse antibiotics in the future. So stay tuned for this. There's a lot of smart people working on this. In terms of treatment, there are 2 new drugs that are out there potentially for treating gonorrhea. Zoliflodacin is out there. What's great about this, it's gone through phase 2 trials. It's a single dose and it's oral, and it does look good that this is going to be approved, and geptidacin as well. Both of these are a DNA synthesis inhibitor, so they work on a different mechanism. It's already gone through phase 2 and phase 3 trials, and I saw on a site that we think that it may be approved in March of 25. So just wait. I'm sure you've seen a lot of ads for use of this drug in UTIs in women. So I hope that it's not going to get overused, and then it'll remove it for us to be able to use it for gonococcal therapy. So again, stewardship in this area is recommended, but stay tuned for those new drugs that are coming out. I don't believe that the studies have looked at pharyngeal disease. I'll have to go back and look at it, but still ceftriaxone is our mainstay for that. So back to Jack. When would you retest Jack for reinfection? I'd test him in 6 months, 3 months at the site of infection, annually, or never. He isn't at risk. Fabulous. You could also make a case for testing at all 3 sites, but you definitely want to test him for reinfection at the site where you originally had your infection. So let's talk a little bit about chlamydia, another favorite. So uncomplicated chlamydia, the preferred regimen, as probably all of you know, is doxycycline, and twice a day for 7 days. There are, of course, we remain with our alternatives of azithromycin, levofloxacin, and amoxicillin in pregnancy. So why the change? So for chlamydia, really, it's about the efficacy. And we know that there were several trials that were done that showed that microbiologic superiority of the doxycycline over azithromycin, and especially in rectal infection. These are two studies that are in CID and in the New England Journal that showed that doxycycline was 20 to 26% superior to azithromycin, especially in eradicating chlamydial infection in the rectum. As I mentioned right in the beginning of this talk, some women have rectal chlamydia infection, either by autoinoculation or from sexual practices that they might not be telling you about. So therefore, in women, you should also use doxycycline. But as practitioners, we know it's about the art of treatment. I don't want to just say follow the guideline, follow the guideline. You have to work with your patients, and you have to, in shared decision-making, decide. It's really about weighing efficacy with the ease of administration. So can somebody get access to doxycycline or azithro? Will they take it for a week? I know I'm really bad about that. What if somebody, and especially our young adults, if they have partners that they have not shared their disease, their infection with, what would they be worried about if somebody sees that they have doxycycline? So you do have to consider all this. There are cases where azithromycin is the preferred drug, so pregnancy, allergy to doxycycline, for example, or if somebody is non-adherent. In addition, like if you're worried somebody is just going to go out and they're not going to pick it up or they're going to wait, then maybe you give them treatment right there, and then you could follow up and say, hey, if you have doxy, you have CT in the rectum, you really should be taking it doxy twice a day. Like, is that cool? And I think giving one, following up with the other is, even though it's not ideal and it's probably more antibiotic than you need, you could also do this. So you have to really be the clinician that you are, work with the situation that you're in. So what about other non-gonococcal urethritis? And I know we talked about yesterday in our STI session, MGen is really the pathogen that's sort of coming up in a lot of discussions because a lot of commercial labs have this pan-STI panel, which is the bane of our existence. So MGen is out there. We don't exactly know the total epidemiology about it, but we know that it does cause urethritis and persistent urethritis in about 15 to 25% of patients. Likewise, there were a couple of cases of Neisseria meningitidis from oral sex that can cause urethritis, so this is something else to think about. I think there was an outbreak in Michigan and Detroit a couple of years ago with that as well. So what do we know about MGen? We know that MGen causes the persistent urethritis symptoms. There is a little bit of data to think that it could be involved in PID. We don't completely know the natural history of it, but population-based screening is not recommended. What is recommended that you test if somebody has persistent urethritis or persistent symptoms. There is the NAT test that's FDA approved that's available for testing. And there are also molecular tests that are available to look for resistance because, again, this is one of those organisms that resistance is incredibly common. In fact, in some sites among MSM, it's up to 70, 80, 90% resistant to azithromycin. So this sort of harkens back to what I was talking about before with gonorrhea. This is the treatment for this organism, maybe how we're going in other STIs. It's resistance-guided therapy. And I'll show you that in 1 second and why that is. The other thing that's different with MGen is that for partners of symptomatic persons, the recommendation is to test them and treat them if they're positive, so not empiric therapy. So that is something that's different, and that's from the other STIs that we've talked about thus far. So for MGen, it's sequential therapy. So if you have resistance testing, that can help guide you. So if you don't have it, the recommendation is to do doxycycline followed by moxifloxacin. Why is that? So the idea is, and this is based on, I think, a single study, but that based on with the doxy, you decrease the total number of pathogens that are there, and then you follow up with moxifloxacin to sort of complete the eradication process. The azithromycin is given if you have resistance testing available. We know that this is difficult in pregnant women. We talked about it yesterday. Oftentimes people will elect to treat with just azithromycin in pregnant women and see what happens. But if women are asymptomatic and pregnant, you do not need to treat them. So just because it rolls out in that multiplex study, you can just have a discussion with them that there are no good studies that show negative outcomes in the pregnancy or for the neonate, and that you can wait till after delivery to treat them. So management of sex partners, I sort of alluded to this a little bit. We really want to evaluate sex partners for their STIs. We want to treat them empirically. And MSM, shared decision making for PEP, is also important. I give you here the guidelines. You're going to use the same treatment that you are giving for your treatment of the patient who has STIs. Do I have a second to go through the rest of it? Yeah? Quickly? So HSV is another thing that was mentioned briefly, I think, also in our dermatologic talk. Really, HSV-1 is occurring more often. The guidelines do have recognized this, and especially because of the increase in oral sex, anogenital HSV-1 is appearing. So it's really important that we test these lesions, identify by PCR whether they're 1 or 2, because it impacts the prognosis, whether they will recur. Testing in the guidelines, if you're doing serology, which I hate HSV serology, but you should do the glycoprotein-specific G protein testing to identify if it's type 1 or type 2. Follow it up with a specific Western blot or a biokit, because there is this lack of specificity, especially if somebody has a low level of antibody in the blood. Never send an IgM, please, 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 please. For HIV, it's really important that what's different in the guidelines is to think about treatment or suppressive treatment for those who are starting on antiretrovirals, because if somebody has a very low CD4 count, we do know that they have, the HSV can come out as part of the IRIS syndrome, and suppressing that and not letting the HSV come out is important. I think we do still suppress for HSV because we want to think about transmission of HSV and transmission of HIV. So suppression has not completely gone away. In addition, it's not completely linked to develop of resistance if somebody is really good about taking it daily. So I think you could still consider HSV suppression, especially in your HIV population. For pregnant women, what's important is to really talk about syndromes. So you want to make sure the woman does not have HSV at the time of delivery. This is critical. So mpox, we also discussed briefly. We know that it's a long incubation period. It goes through all these stages. What's important for you to know is that those who have severe disease were the patients with HIV, and HIV with low CD4s, and I think Dr. Cheever spoke about that yesterday. Multiple dermatologic involvement, oral, rectal, incredibly painful. Those who died in the US from mpox were those who were severely immunosuppressed. Treatment is not great. We did talk about tecovirimat. You can get an IND. We have a standing IND in our institution to be able to give tecovirimat to our patients who come in. That is one way around getting the treatment. Although the recent studies that were just released from the DRC in Congo really showed that tecovirimat was not that efficacious. Combination therapy is now actually being used with brincidofovir, intralesional cidofovir, and tecovirimat. As mentioned, vaccination is going to be key. Vaccinating those who are at risk is key. And I'll just list here some of the questions that have come up. Pregnancy is not a contraindication. There's no booster that's needed. So what's new in HIV is really equity. Point-of-care testing hopefully will come. Direct-to-consumer testing. I Want the Kit is out there. DoxyPep has been discussed. That I think is also important in vaccines. Men-B coverage to help with GC. There are national registries now for resistance. MGen is part of it. And this Cargos Combating Antimicrobial Resistance for GC and Other STIs was also established in August. So if you have questions, contact us. The STD prevention and training centers, we can help you out with patients. We do have also that warm line that you can send us questions to. Apologize for going over.
Okay, so we have about 10 minutes for questions. So one question is about whether or not you should routinely do oropharyngeal chlamydia testing.
You guys are so clever. So they're linked. So there's no way you can unlink them, gonorrhea and chlamydia. So the test results come up. I treat it if it's there. Yeah.
And for rectal chlamydia, do you treat for, if you're using Doxy, 21 days or 7 days?
So if somebody doesn't have LGV, you can treat for 7 days. If somebody has persistent symptoms, and it's more than if you see like severe adenopathy or fistulas, you definitely have to treat longer, 21 days.
Okay, and how common is LGV proportionally?
For me, not too common. I think it's very low incidence compared to just rectal chlamydia.
And should you be providing expedited partner therapies for gonorrhea or syphilis? Like, how do you handle that?
So EPT for GC, you have to look at, each state is different. So you have to look at your state laws. COVID was really good for one thing. It let us give EPT to a lot of people. But so you can do it for GC with Cefixime if you can get it. Syphilis, no, there is really, I don't give Doxy, and it's not recommended to give EPT for syphilis. You really want people to come in.
Great. And a couple of questions here about a patient who is positive, but they're for an STD, including like trick, and then their partner is negative. Like, how common is that? Should that surprise you? What would you do? Would you treat them anyway?
So that trick is complicated. That can be transmitted. Men do get trick, but I probably would do an evaluation first. I mean, you're testing somebody at one point in time. It doesn't mean that they don't actually have it. So I tend to treat partners for STIs, especially chlamydia and gonorrhea, I think is important. Trick, you might have a little bit of leeway with that because the negative outcomes for that might not be as significant.
Great. Question at the...
I feel like there's been a lot of back and forth about that.
I know, right?
Yeah.
Like, I was confused too. But the Men-B vaccine, there was data maybe in 2020 that came out from Australia studies that it looked like it was going to be good against it, and then to preventing as a strategy for decreasing gonorrhea. Some recent studies showed that it wasn't, and now there's another trial with I think a 4C Men-B vaccine that looks like it might still be good. So I think it's still, you're right, that it is a little bit controversial.
If someone's had Mpox, do they need the Mpox vaccine?
No, thank you. Exactly. If you have Mpox, you do not need to be vaccinated.
Okay.
But people don't come back for the second Mpox vaccine. So really make an effort to get them in for both. I think it's super important. And my guys are always asking me, like, oh, is it really out there? Come on. And I'm like, well, do you really want it? Like, I don't know, I would get vaccinated. Like, it hurts. And there's a lot of scarring. And, you know, people who have severe disease, it can be devastating. Why not get vaccinated? Easy.
It was just mentioned here that you can enroll in the STOMP trial, and that's a way of getting treatment quite easily for Mpox without having to do a lot of, you do a different kind of paperwork.
Yeah. Stump trial, yes, absolutely.
So consider enrolling. Is your
Conflict of interest, we have that at our center.
okay? Well, I can say that there. Okay, ureaplasma, is it a real pathogen?
No.
Okay, so what happens if you're trying to give IM treatment for STIs and a patient has implants? How do you manage that? Like buttocks implants?
Yeah, I think that is difficult. Ceftriaxone you can give in the arm, which we usually do, so I think that there is a way around that, and it is well absorbed given in the deltoid.
So one person was talking about the difficulty of getting gentamicin IM even from pharmacies.
Yes.
So what can azithromycin be paired with if you don't have access to gentamicin in a patient with a penicillin allergy?
So, cefixime you could probably use. I think it's a different R group. I would definitely confirm the penicillin allergy for the ceftriaxone. I definitely have guys who, they say I have a penicillin allergy and I've given them multiple doses of ceftriaxone without a problem. I think you can use the 2 grams of azithromycin if you're really, really worried, but you really have to have close follow-up.
Okay.
And talk to your PharmD. They are an amazing, amazing resource. And just a single call, I have my PharmD on speed dial. So we don't know everything. I definitely look everything up all the time. I think that makes you a better doctor or a clinician. So look it up if you don't know.
So there's a question about treating asymptomatic pharyngeal chlamydia and maybe GC. Should you treat it if it's asymptomatic?
See, I just worry people have a lot of oral sex, so I tend to treat it. I mean, I could be wrong, but that is a good study. Whoever asked that question, do that study.
Great. Okay. Thank you. And so there was a question.
But maybe it won't be funded.
Okay. So now my train of thought was completely screwed up. I think one of the questions was, so we know that untreated chlamydia and gonorrhea can have complications for women in the GU tract. What about orally or rectally? Like if it was untreated for years, what would it?
Yeah, rectally for sure. You can get fistulas, you can get epididymitis, you can get. And also, you know, everything is sort of linked down there to be graphic. So I wouldn't say that it's just going to stay there. Pharyngally, I don't think we have any data on that.
And someone just had a question about how if clade 1 mpox, there's now 1 case in the United States from a traveler.
Yes, just released.
Yes. How should it be treated? Should it be seen?
Wow. There you go. I mean, I definitely think infection control and prevention is incredibly important in that situation. I think people would give tecovirimat anyway, and I think people are going to, depending on how severe it is, people are doing combination therapy.
Great. And how often are you scheduling STI treatment for patients on injectable PrEP with a 2-month 2-month cycle of PrEP injection? How often are you actually testing for STIs?
I just offer testing all the time. So anytime, I mean, I'm probably living in la la land with funding. I'm hoping my patients don't get bills. I just test whenever they come in because everyone's having sex all the time. So, I mean, that's my, yeah. It's like, you know, when we talk about syphilis, like what a rash, my kids are like, that's not syphilis. I'm like, it could be syphilis. So I just assume everyone's having sex, no one's using protection, and you should test all the time.
Okay, philosophy to live by. Will MGen,
My poor children.
Will MGen grow in urine culture, or do you need to have a NAT test for MGen?
You need the NAT. I think there's only one place, Alabama, that offers culturing, yeah, you need the NAT.
Okay, and if you're treating a patient for or suppressing a patient for herpes who has HIV and they're well controlled and their viral load, I mean they're well controlled and the CD4 count is high, should you dose them as if they're immunocompromised or dose them would otherwise be recommended?
Good question. I mean, most of the guidelines are like, there are specific recommendations for HIV patients in terms of treatment and dosing. So I would follow that would follow that guidance. I think that, I don't know, I kind of make it, I'm not, you can hear me say that, Valtrex dosing all the time. And not make it up, but you have to sort of work with the patient. Can they do do they want to do single daily dosing or 2 days or do with suppressive therapy? So I think it's also what works for your patient, what are they going to do? Oh, there's something.
Okay. Oh, so
But I would follow the guidelines.
this is HSV2 versus 1.
For HSV1, we don't treat with prophylaxis. We don't treat suppressive HSV1.
HSV1 is not treated with prophylactic suppression because it doesn't work. We have one at the mic, and then that'll be the last question.
So my question was about if you did a test of cure for pharyngeal gonorrhea and it's still positive. So what's your plan B? And you've ruled out reinfection.
I'm sorry, can you repeat that?
Pharyngeal gonorrhea, if your test of cure is still positive, what do you do in that case? And you ruled out reinfection
So for gonorrhea,
in the pharynx.
oh,
Yeah.
failed in the pharynx. And so the recommendation is to do both a culture and a NAT at the same. If somebody comes back in with symptoms, you can automatically do a culture and do a NAT at the same time. If you're just doing it empirically and they're positive, I would retreat with the same. You can either do the same dose or you can do the gent azithro. You can also increase your dose if you want. There's a couple of different ways to go at it, but I definitely would send a culture if somebody's coming back and they're symptomatic still with disease. I would do a culture to look for susceptibility testing.
Thank you.
Great, so thanks so much for that. So thank you very much. That was great. Here are your cards for later today. Okay.